Hey everyone, thanks for joining us. I've got an amazing expert with me this morning, my good friend Kyra Smith. She is a licensed midwife and a certified professional midwife, and she works out of her own clinic, which is one of 2 birth centers in the state of Louisiana.
3
right?
actually, but only 2 that are midwife owned.
So that's really cool, and we have that right here in Broussard, Louisiana. Crazy,
Walking
right?
distance to your office.
Walking distance, around the corner. So we share a lot of clientele. She does amazing things. I intend to have my kids with her whenever that day comes, but I'd like to talk a little bit today about your expertise and what you know. So let's get right into it. My first question for you is, what are the biggest differences between births in a hospital setting versus births at like a natural birthing center where you work, where you practice out of?
So as a midwife, we deal with low-risk, healthy, pregnant women and their low-risk term babies. So one of the biggest differences is that out-of-hospital births are only for healthy, low-risk women, which, largely is a big probably part of your clientele as well. Our practice focuses on health and the normalcy of pregnancy and the normalcy of birth. And so births outside of the hospital are a lot more hands-off. We do fetal heart tone monitoring, we do check vitals, we obviously deliver the babies and whatnot, but it's in a more home-like setting with a lot less unnecessary interventions. In our practice, clients can deliver in whatever position they want, they can invite however many people they want to their birth, they eat and drink in labor, which is very unusual in a hospital setting. And really, as long as things are normal, we kind of let them be normal and they can have their baby however they want. OB practices are a little bit different. They have a higher client volume, so where I might take 5 clients a month, they typically take about 25 or 30 a month.
Oh, wow.
So you can imagine that the time even in prenatals and clinic together is not as personal because they just don't have the time. They're seeing a lot of clients.
Yeah.
And then the births themselves, as a midwife, we come out, we attend the birth as the labor and delivery nurse and the person who delivers the baby, and we do all the newborn care. But at the hospital, OBGYNs, they'll come in, they'll say hi, but really they're coming in when you're pushing. They deliver the baby and they step out. You do most of your care with a nurse.
Yep.
So there's that continuity of care aspect that women really, really love, that personalized care that midwives provide. Just because we have that low client volume, we have the ability to do that.
It's more concierge, if you will. Like you can really focus in on this person, and I would imagine that, not to say anything about an obstetric practice, it's a different model of practicing, but you probably have like a very, very good relationship and understanding with this mom or with their whole family.
Right.
And you can kind of play off of that. Like, for example, I find that I have very good relationships with my clients because we work with them hands-on, and I analyze their stuff so much before they come in that I feel like I know them before that I really know them.
Right.
And it allows me to provide a higher quality of care as well. You said a couple of things, and you're jumping the gun because I want to get to a couple of those topics. But 25 to 30 patients on average per month is more than 1 per day if you only work Monday to Friday.
Well, and you have to keep in mind too, they're not just seeing pregnant women, they also have a GYN practice.
Right.
So on top of this, they're doing their GYN surgeries and all those other things that they have to do.
Wellness exams, and that's a lot of work.
Yearlies, and it's a lot.
How many of them do you know, like, this is probably gonna be a hard question to answer, there's no like hard data on it, but how many of them do you think go and deliver on weekends? Is that kind of an off thing, or do they try to streamline it to stay within the work week?
I think for them to have enough of a balanced life to be able to be good OBGYNs and have a life at home with their family, that it's fair for them to take their weekends off.
Sure.
Even there are some doctors who will come out for certain clients, no matter the day or time that they deliver, but it would be unrealistic to expect them to take on 30 clients a month, 12 months out of the year, and be on call 24/7. I mean, they wouldn't be good doctors, they'd be exhausted, right?
Yeah.
Not to mention husbands or wives, and they'd be exhausted.
So the reason you can do it is because you have a lower client volume.
I deliberately keep my client volume low because it is important to midwives to have that relationship.
I still see pictures on your social media. I'm like, gosh, she delivered another one this week. That's crazy.
Just wait till November.
Oh, geez.
In December.
Are people surprised when they find out about the term you used was continuity? are they surprised by the discontinuity of like an obstetric practice?
No, because around here, that's what everyone's used to. They're used to the busyness of the OB practice. They're used to waiting for an hour to see their doctor. Not speaking bad of doctors, by the way. This is just a different model of care. They're used to that. So when they come into my practice, even like the consult, I'll say, our client appointments are 30 to 45 minutes in length. And I had one client who was like, what are we gonna talk about for 30 minutes? And then later she's
your
like,
health history.
I love that we spend so much time together. I look forward to our appointments. So it's just they're used to it. This is unique to Louisiana model of care, but Washington State, Florida, New York, and the Amish areas, this is expected over there.
Interesting. So it's like it's a different culture is what it is within a practice. So should I be worried about not being in a hospital setting to have my baby, or having my OB present at my birth? Should I be worried about those things?
So,
I think I'm scared, like I need my doctor,
Midwives are skilled, or how do I say this? Midwives have very skilled hands, but we know how to sit on them. So midwives are trained to do all of the things that keep birth safe. I mean, we're licensed by the state. We're very heavily regulated. We have rules and protocols and policies to keep our clients safe. It's just a different model of care. So no, you shouldn't feel afraid. If anything, you should feel cared for, safe, pampered while you're experiencing an out-of-hospital birth.
Okay, so a lot of people would say, it's not about what you learned in a book or in a classroom. It's about your experience, right? How many times have you done this? How long have you been doing it? So how long has midwifery been around versus obstetric practice?
Midwifery is the oldest profession in the Bible.
Wow, there it is.
So midwives have always been
nothing to worry
around.
about. Yeah, over 2,000 years, y'all,
but
or more.
Now we have medical training. We have training, and we're being more accepted in the medical community, so we're getting more hands-on experience. We have a more, like a clearer model of apprenticeship. So there's a certain amount of births and certain amount of experiences we have to experience before we can get our license. So for example, it took me 5 years to get enough numbers to become a midwife, because midwives have a low client volume, right? But how many people, even labor and delivery nurses, do you know that have attended 200 natural births and sat with them all day, all night until they delivered, and then followed them before and after? It's just a different model.
But when you say it like that, I feel much more comfortable with you delivering my kids, because it's like she's seen this hundreds of times, and now she does it on her own hundreds of times, and this practice has been around for thousands of years. Like, it's also, we're kind of getting into maybe a question a couple minutes later, but this is what our bodies were designed to do. There should not be any fear around getting up out of bed and walking to the bathroom to brush your teeth, or to use the bathroom, or anything that you do to get ready in the morning, because that's what your body is designed to do. There should be no fear around it. Same way, there is some inherent risk with getting in your car and driving to work. There's some inherent risk with maybe eating a certain food that you decide to eat for breakfast that could negatively affect your health. And there's an inherent risk when trying to deliver a child. But let's not forget, God equipped us with some pretty cool mechanisms to be able to do that. Do you want to talk a little bit about the normal physiology of birth?
Yes.
And some of the things, maybe the cool, fascinating things that the lady's body does in order to deliver. You want to talk about that a little bit?
Before I hop onto that though, something you said reminded me, a client had said this week. Going to see a midwife is not like, oh, my neighbor's delivering my baby and we're good. Again, there's protocols and policies in place that keep women safe, and it is backed up by evidence and science. And the more studies they're doing on midwifery, the more they're like, oh, midwifery for low-risk healthy women is not only equivalently safe, it may even be slightly safer. So it's not like your neighbor's delivering your baby, it's a skilled midwife.
Right.
But so birth is natural, and for healthy, low-risk women, the more you leave it alone, the safer it is. What happens around here is that everyone thinks that they won't fall into that low-risk category. They're 36 or 40 years old, or maybe they had a cousin who hemorrhaged, or whatever the case may be. Everyone assumes that they're not low risk, But the fact is over 90% of Acadiana is low risk pregnancies. And it's very particular circumstances that would not be a candidate. For example, premature deliveries wouldn't be a candidate.
Yep.
Women who have epilepsy or on medication, but not the typical average woman who is just, pregnant.
Yep.
And so, again, so for healthy low risk women, the safer, birth is safer the more we leave it alone. And so it doesn't need that continuous monitoring, strapped down to monitors, following you around the room, frequent vaginal exams. Like, none of that is necessary to have a baby. And like you were saying, we don't get nervous when we get in our car or we go brush our teeth. These are normal things that we do. Believe it or not, birth is extremely normal too. Like, you're gonna deliver your baby even if your midwife or your doctor doesn't.
One of the reasons that I would really like to use you for myself, my wife.
Your wife.
It's only 2019, we haven't gotten that far yet. Is because you talk a lot about the philosophy of sitting on your hands, the lifeguard thing that you mentioned. It's more about only doing what is necessary.
Right.
Less is more. And I would only go to an obstetrician who felt the same way. It has nothing to do with OB or midwife or conventional versus crunchy hippie. It's more of the philosophy. And the reason that I like the whole sit on your hands thing, like only do something if absolutely necessary, is because of what we like to call the intervention cascade. Now this is what happens when the first intervention happens, and then it usually begets more and more and more a positive feedback cycle. So you want to talk about that a little bit?
It's almost like a self-fulfilling prophecy in labor. A woman walks into labor thinking, something's wrong with me, I need to be induced because I'm 30, 39 weeks or 40 weeks, I'm at my due date. What if I go over?
Due date.
So, right. And so she allows herself to be induced, and that induction kind of escalates. So Pitocin is used to induce, and it makes—
It's a hormone, right?
It's a synthetic hormone, which makes contractions stronger, longer, and more painful than anything that they would experience naturally.
More painful?
Yes.
Oh, okay.
And longer.
Is it that so it's not that painful if you allow your body to do this on its
Natural
own?
birth is really interesting. I think a lot of people assume that when they're going natural, they're going to suffer through it.
Yeah, like no epidural.
It's not like that. If you let women get in positions they want, eat and drink in labor, connect with their husbands, their labor, they're still working hard, but they're not suffering. Kind of like bodybuilders. They lift weights, they make a lot of noise. Nobody thinks they're suffering. We know that they're working hard.
Yeah. Pregnancy
and labor's just like that.
Yep. Hans Selye talks about eustress. You familiar with that? Eustress, meaning EUSTRESS, good stress. So there's a certain amount of stress, like when we work out, that it breaks down muscle tissues, but it's going to initiate an adaptation response that's going to make you stronger, and your body is totally designed to do this in order to adapt and evolve. And I truly think that the birthing process is the same way. You're using a muscle, it's contracting to go through this whole process. Maybe the first one, there's a little bit of getting used to it, but usually the second, the third, the fourth, the eighth, however many kids you want to have, especially if you're doing natural family planning, it almost gets easier each time because the body is used to it and it's already been through that. So you talked about Pitocin. Do you think that without Pitocin, it's really not, it won't get to that level of painful or pain where you would need to use an epidural? Because that's usually the big thing. I don't want to do natural because I'm afraid that, no epidural, I'm going to die,
So there's more to birth than just the power of the uterus. It depends on the passenger, the baby, the psyche, how mother's feeling. Is she in a safe environment? Does she feel loved and supported? What's her stress levels going on? That all play into a woman's pain threshold during labor. So for example, I had a friend whose father passed away shortly before she went into labor, or I think she may have been induced, but her father passed away. So even though she wanted a natural birth, her emotional psyche was not in the place to be pushing through something like that, and she ultimately got an epidural, and thank God that we have those for those kind of circumstances. But for the average woman whose baby's cooperating, which again, midwifery can help with that kind of stuff because we use position changes to help baby cooperate, whose emotional place is in the right place, they feel loved and supported and cared for and safe where they give birth, and their uterus is doing its job, because they're healthy and they're nourished and they've had chiropractic care and they have exercise and eaten well throughout their pregnancy. Birth you know, it's intense, but it's not that bad. And look, this is coming from someone who has the weakest pain tolerance you've ever met. And I've had 2 natural births, and I'd do it again. I had a home birth for my second. I am a big baby when it comes to pain, but birth is different. It's hard work, but it's not overly painful. And if it is, if a woman is truly suffering, which I've seen, something's wrong, and every time that has been true.
Yeah, your red light goes off, and it's like, okay,
something's not right.
Right, we can intervene if necessary.
Absolutely.
And that safety net is always underneath. You would never initiate a delivery in your practice. Home birth maybe a little bit different, but you would never initiate a delivery in your practice without that safety net underneath you. Right?
Absolutely, and home birth is the same thing as what we do. Same midwife, same training, different location.
Okay. Open your phone again for me.
So we're talking about the snowball effect.
Yep. You want to talk more on that?
Yeah, so this idea of the snowball effect is essentially one intervention leads to multiple other interventions.
Yep.
So for example, a woman's at her due date, agrees to an induction, receives Pitocin. She wanted a natural birth, but Pitocin makes her contractions longer, stronger, and closer together than she would have experienced naturally, and now the pain is too much to bear. And she's not making progress very quickly because it's her first birth, right? So she receives the epidural. Epidural tends to drop our blood pressure, which requires IV fluids to bump them up. So now we're hooked up to IV fluids. We've got an epidural. We have a catheter because we can't get up to go pee when we have an epidural, and we're stuck in the bed. Well, now that we're on our backs in the bed and we're rotating side to side, it is very common for birth to go a little longer, be a little slower. And even though we're not feeling it, our babies are feeling it. Well, Pitocin and contractions can stress out the baby, which is why we're monitoring. And if baby starts to get stressed out, now we're putting on oxygen, now we're bumping you up with more fluids, and sometimes it does escalate to the point that we need a C-section to save the baby who's not doing well, that came from the epidural, that came from the Pitocin, that started with the idea of being induced because we're past our due date.
Due date, right.
It's just this snowball effect that's awful.
Right, and in theory, and this doesn't happen every time, y'all, but
No, definitely not.
In theory, what if the baby knew that its due date, like he was ready to come in 3 days, right? His plane ticket was on Friday, but we said, no, he needs to be here on Tuesday because it's been 40 weeks or whatever, the term since we...
Or a holiday's right. Coming, your baby's got to come out.
Yeah, you got to come. So, let's go ahead and induce. And he's like, whoa, I was going to come in 3 days.
Yeah.
If we would have just waited, a lot of this stuff could have happened naturally, the way God designed it, the way our bodies are designed to do it.
And it goes faster and smoother and easier when you let it happen the way it's supposed to.
Yeah.
Now, that's not saying that these things aren't important. Being a midwife, there are the occasional times that we do need to take a client into the hospital for an induction or an epidural, or even a C-section. And I am so thankful to live in a country where we have safe access to very safe medical care. It's the use of this unnecessarily or jumping in on these interventions that you don't necessarily need.
Yeah.
And you really don't have a relationship with your healthcare provider to navigate whether or not you actually need this. And what's happening is Louisiana specifically is having one of the highest maternal death rates, one of the highest neonatal mortality, morbidity rates.
Yep.
There's just so many issues. C-section rate.
Highest C-section rate.
C-section rate, highest or one of the highest, if not in the country. It's above 40%. So almost every other first-time mom who walks into the hospital has a C-section, and y'all right here in Lafayette. And it's not that we don't have good doctors, we have to meet them halfway.
Here's the thing, I feel like when you understand a mechanism, especially something about the body, it's cool, right? Most doctors we're all nerds, we can, if we understand something, it's like, oh, that's so cool, and we try to use it to our advantage to improve the human experience. But there's this blurry line where you may not even realize it. Sometimes arrogance about that can make you make a decision thinking, oh, I know what's best for this person's body. That person's body does not know what it's doing.
Right.
And so we intervene. And so maybe that's necessary, but that is the hardest decision to make, is should I give this first intervention? Because once you do that first intervention, like you said, you're overriding some natural mechanism of the body, and so other things will not be able to happen in a sequential manner the way it's designed, so you have to override for the next one, and the next one, and the next one, and this synthetic labor is often more painful, longer, and
it has bad outcomes.
Bad outcomes.
But this is where midwifery care shines, because we believe it's something called shared decision making and obviously informed consent. And what that means is I lay a problem out in front of a client and I'll say, here's what I see. Here's all of our options, both the medical ones and the natural ones, and let's talk about what all of your options are and make a decision on the best course of action from here together. And so I'm empowering the families with information that they didn't have access to in a non-biased way, and I give them my opinion, my medical opinion, and what their doctor's opinion is, and let them make decisions. And at the end of the day, every woman deserves to be able to make an informed decision, whether or not it's something that we agree with.
Yep.
And they have a right to do that. I mean, every mom is doing what's best for her and her baby. And if that's the case, then we need to empower them with the information to do that. And again, that's where midwifery shines, because we take the time with our client to jump into these deep conversations so they can make informed decisions.
Makes sense. Biomechanics. So in your pelvis, when you are walking, gait, for example, you have the sacrum, the tailbone in the middle, and the two ilia, the iliums, the hip bones on each side, right? Mm-hmm. When you walk, you're going to experience two forms of movement. So on one side, there will be what we call nutation, which is where the sacrum kind of dips forward and down, and the ilium or the hip kind of comes back, right? On the other side, simultaneously, you have counter nutation. So that side of the sacrum is kind of moving back and the hip is moving forward. So basically it goes through this right here, back, front, and they're doing opposites of each other, and then each side is doing opposites of each other, right? In birth, it's the only time that you see the pelvis break the rules. What's it called when like basically sacrum comes back and ilium opens up as well?
We don't deal with those terms.
It's like the triangle of.
Oh yeah.
What is that called?
Oh, it's not going to come to me because
whatever it is, it's the coolest thing ever.
It's amazing.
Because your body is so freaking smart, and we should trust this thing that it literally breaks its own rules when necessary in order to initiate this or to carry out, to execute this laboring process, right? But you'll only see this normal opening of the pelvis, which you need if you're trying to deliver a baby. You only see this normal opening of the pelvis if you're not lying on your back. Right? You have to be squatting, bending forward, something like that.
Lying on your back on that, I wish I could remember the term. Of course we can't right now, but that part of your sacrum that kind of elevates at the end of labor.
Yep.
When you're laying on your back, you're actually closing your pelvis by about 30% when you're pushing.
And there's no way that it can open when your weight as well as your baby's weight is on the pelvis. It doesn't make any sense. So why do women get in stirrups?
It's convenient for the doctors.
It is.
It really is.
When you're seeing volume like that, again, like she was talking about the human
convenient.
thing, you need your weekends if you're seeing 30 patients a month.
You got someone delivering across the hall. You have 10 people waiting for you in clinic.
Nothing wrong with that, but it should only be used in an emergency situation. Right? If we're dealing with a low risk labor, 95% of women, it should be the way that our bodies were designed to do it first.
Right.
Maybe bending forward, allowing for the opening of the pelvis, and then once the baby starts to descend through, the sacrum actually totally flips itself, like you said, and it allows for that process to occur. So y'all, if you're not under chiropractic care, if you're not getting the proper consulting done through your pregnancy and labor, I highly recommend that you call my friend Kyra, even if it's just for questions. We tried to give you all as much information as we could in half an hour. Is there anything else that you want to add as far as like what might be different as far as someone's experience in your office, even if they're not ready to fully commit to this yet?
No, I think the best thing to do is if you don't explore your birth options, you really don't have any. And so if you're pregnant, you don't have to know if you're low risk. You can call us, come in for a consultation. We can help you find out if you're low risk, if you're even a candidate, and we can point you in the direction of all of your birth options. Because at the end of the day, you don't know what options you have unless you go out and you explore them.
Right. So it would behoove you guys to give her a call and just pick her brain whether you want to deliver naturally or not. Anything you'd like to add before we get out of here? I know you're busy.
No, I mean, you guys can follow me on my YouTube channel. I have a lot of this information there where we talk everything about if you're not pushing on your back, what other positions are there? A lot of people don't know that there are alternative pushing positions.
I think we should do a follow-up too, because a lot of times I'm throwing in little nuggets about tricks that even the husband can get involved and do to help mom through like a difficult contraction or a laboring process. So maybe we'll
Yeah.
do that on a later video. But
Part 2.
thank you guys for joining us. Thank you, Kyra, for
Thanks.
being with me today and sharing your knowledge and your wisdom. You can look at her up at The Natural Birth House in Broussard, Louisiana, and all your handles on YouTube, Twitter, all that stuff.
CajunStork.
CajunStork, yeah. Thank you guys, and
Bye,
have a good
guys.
one.